Hello, everyone, and welcome to our webinar this evening on continuous diffusion of oxygen, promoting cost effectiveness and patient independence in wound healing. And before we get started, I'd just like to go over a few housekeeping items so that you know how to participate in today's event. You can submit questions to our presenters by typing them into the question panel found by clicking on the Q&A icon along the bottom menu. You may submit your questions at any time and we'll collect them and address them actually in the Q&A portion at the end of the session. So our objectives for today's session are to review a recent health economics evaluation on continuous diffusion of oxygen, learn about the supportive science behind CDO, and we've got some really interesting cases that demonstrate patient independence, wound healing, limb salvage, and pain management while doing CDO. I'd like now to introduce Edie Attrell, who graduated from nursing in 1975, and she completed her degree at the University of Calgary in 1995. She became an ET nurse, now called an NSWAC nurse, in 2000 and received a certificate of completion in the International Interdisciplinary Wound Care course from the University of Toronto in 2002. Edie has worked in various capacities for Alberta Health Services with the focus on skin and wound care and management, education, and supporting practice change. She's also a national consultant for EO2. So Edie's presentation starts with one of her patients, Bill, talking about his experience with CDO and how he was able to manage it independently.
I have had 2 wounds, one of which has healed. We used iodosorb pretty well as the mainstay, and it took its time, but it worked. I got a second wound in middle of March, roughly. Used the same sort of protocol, but it didn't seem to be moving forward as it was. So clinicians suggested we try EO2, and I said, sure, I'm game for that. So I had a piece of equipment sent to me along with the dressings. I followed the instructions. Took 2 days to get comfortable with the process. I was able to wear athletic shorts during the time with EO2. I wore the equipment underneath the shorts. It worked very well. The tubing was not an issue after a couple of days, and using compression socks to make sure the tubing didn't get snagged anywhere. Changing the dressings was no problem. It was actually quite simple once you had the confidence that it wasn't going to really blow up on you. It took just a matter of short minutes to unscrew tubes, take off dressing, put new dressing on, and then rehook it up. The during the time period, the wound got smaller and smaller, which was nice. But during that time, I did have electronic access via text or pictures to the clinician, and was able to just discuss it as it was proceeding. So although I was doing all of this at home, it was as if someone was with me. The wound, as I said, got smaller and smaller, and hopefully in the next week or so it will have gone away. I had good results, and I'm very happy with the use of it, and when I look back on it, it really was a very simple process. So I am quite happy with the results.
Good morning. I'd like to share a patient with you, Bill, who is 73 years old. has been diagnosed with prediabetes and marginal venous insufficiency. In March of 2020, he noticed a small red area on the lower leg that broke open, and he was self-treating, leaving it open to the air to dry out, which he thought was a good strategy. Unfortunately, the wound kept getting bigger and there was an increase in drainage, so he started using Band-Aids to cover the wound and then moved to a gauze dressing to cover the area. And at that point, home care became involved. This is the picture of Bill's wound on April 30th. And he also indicated that the area was quite painful. There was slough present, quite poor looking granulation tissue. The peri-wound area was pink, reddish, but not warm to touch. And measurements taken by the patient at that time were 2.5 by 2.8. So a dressing protocol was created. We used polycadexmer iodine with an absorptive foam dressing for 14 days. And the rationale for that was to address the bacterial load, provide some autolytic debridement, and absorb the exudate, and potentially address biofilm if that may have been present. His vascular status, he did have some lower limb edema, stating that the edema was less in the morning and increasing throughout the day. He has no lower limb assessment at that point, and that was recommended. And he did have pedal pulses taken by his partner, and he also had 20 to 30 milligram milligram compression stockings, which he was not wearing. He was concerned about wearing compression over his wound. But he was supported to start wearing his compression stockings and to don them in the morning and doff them at bedtime. And we also requested a lower limb assessment to see what his vascular status was. His lower limb skin was also very dry, so a medical grade cream was also encouraged. And because he had some venous insufficiency, he was directed to do a patch test before he applied the cream to his full limb. He was given education to support his confidence and success in completing his dressing changes, as well as managing his own wound care. He was to monitor his wound, so we talked about what he was to look for, the drainage, what the wound bed colors looked like, if there was yellow sloughy material or red granulation tissue in the bed, the drainage, the amount of drainage he was having, and if there was odor and if the amount changed. And we wanted to reduce or minimize cross-contamination and potential recurrent wound infections. So we talked a little bit about storing and caring for his supplies, proper cleaning instructions, hand washing, changes in his wound pain or discomfort, and not to peek at his wound, which Bill did admit that he liked to do on a frequent basis. So after 2 months of moist wound healing, when he started putting dressings over his wound, that's when I got involved. Lower leg assessment still hadn't been completed, and we initiated EO2 on May 15th after the 14 days of antimicrobial therapy. On June 14th, he needed another round. We did a primary dressing again for 14 days, and the patient was very engaged with his care, and we communicated quite successfully electronically. He's even sending me diagrams as well as photographs. This is the timeline, the progression of his wound over the next 2 months, and you can see that each photograph shows a change in size over time. So the EO2 was working very well for him. So in conclusion, Bill has his wound for 6 months. As you can see from the last photograph, he is back down to wearing a Band-Aid over the wound. EO2 was discontinued as he felt that the wound was almost closed, and he wanted to see if his body could get to full closure on its own. So he had 2 months of his own management, 2 months of home care management, and very little change, 2 months of EO2. And at that point, we started to see the migrating edges supporting progression to wound closure. He was wearing his compression hosiery over the EO2 dressing, and that was not an issue for him. He was able to complete his dressing changes independently at home, and through professional assessments via the photos and periodic phone calls to me, coupled with periodic home care visits, we were able to successfully get his wound to a place where we're looking at closure over the next week or so. Patient education and ongoing support promoted success for this client, and it was ending up being very cost efficient because he felt very comfortable and confident in doing his dressings independently. Thank you.
Now, I'd like to introduce Dr. Mark Niederauer. Mark earned a PhD in biochemical engineering with a focus in genetics from Iowa State University. He is a Fulbright Scholar from Stuttgart, Germany, and a Fellow of the American Institute of Medical and Biological Engineering. He has more than 25 years experience in research development, manufacturing, and commercialization of pharmaceuticals and medical devices for tissue repair, including surgical instruments, resorbable scaffolds, dressings, wound oxygenation and monitoring, and electromechanical diagnostics. He has numerous publications and is the co-inventor of multiple patents for devices and methods used in orthopedic surgery, tissue engineering, and wound care. Please take it away, Mark.
Thank you, Karen. I appreciate the introduction. Good evening, everyone. Tonight we're going to talk a little bit about most recent evidence we have and current underlying factors for why CDO works in wound healing. I'm going to start, next slide. I'm going to start with a double-blinded study that was actually fully blinded. Both the patients and clinicians were blinded, as you can see here visually. This study involved oxygen going to a wound dressing with offloading, and the entire systems were identical in both arms. The only difference was in the placebo arm that it was an active device, but the oxygen flowed inside the device that did not go to the wound bed. Otherwise, all the dressings, offloading, everything else was identical. Next. So an overview of how the study was set up, we were looking at primary the outcome being full wound closure. Secondary outcomes, which I'm going to focus on first, included time to wound closure, effect of the baseline wound size on wound closure rates, and also effect of wound chronicity, because we had a run-in period, which only moist wound therapy is applied in both arms prior to applying CDO devices. And we looked at how fast the wounds were closing during that part. This is conducted in the continental United States, 134 centers with 146 patients. And the demographics were identical in both arms, even in the sub-analyses. Next. So first, looking at the time to wound closure, we looked at time to reach 50%, 75%, and 100% wound closure. And you can see overall, including all patients that dropped, so 146 patients, we saw a significant decrease in the amount of time to get to each one of those stages. For example, if you look at the time to 50, it was almost half, and statistical significance of 0.001. Next. Now, looking at wound size, what we agreed to do there was look at the wound sizes we had and divide into quartiles. Each quartile group had similar numbers in both active and placebo. And what you see on the axis, the y-axis, is the relative performance, so the number of wounds that closed in CDO versus the placebo. And on the bottom, you can see the median wound size, and you see as the wounds get larger, the relative effect became greater. Next. And this is something we similarly see in wound chronicity and other areas too, which I'll cover here in a minute. Here, this graph shows something similar. You can see on the left, that bullet, that's our overall results. That was our inclusion criteria. It was about double the amount of wounds that closed with CDO versus motion therapy alone. So basically, motion therapy adding oxygen to the wound. As you go towards the more chronic wounds, which we assessed by removing wounds that weren't they closed quicker during the run-in period, you can see that the relative performance increased from more than twice as much to more than 3 times as much. And what's also interesting, because the delta became larger, the statistical significance actually increased, even though there's fewer patients. And this is a common theme. I think I mentioned this before, that it appears the more you need CDO, the better it works. Next slide. So in summary, this study was published in Journal of Wound Care and more recently in Wounds. It was designed with the United States Center for Medicare and Medicaid Services, which is our reimbursement agency. And they cited this as being the gold standard for how states should be going forward. In summary, you can see in the papers, there's more results published than what we talked about here. Overall, we closed more than twice as many wounds. However, as the wounds got larger, more chronic, we're in weight-bearing surfaces, so on the plantar aspect of the foot, and frequently debrided wounds, the delta, the results got better for CDO. And interestingly, when we look at the patients that dropped due to severe infection, for hospitalization, CDO resulted in 75% decrease in severe hospitalizations. Next. The next study I want to talk about is a pain study. This is a pilot study done with 20 patients. This was done by a group of nurses up in Chicago. This was set up so that the nurses could choose wounds as long as they were painful. They could choose what type of wounds they wanted to treat and see which ones responded best. Next slide. So what you'll see on this next slide is that they tended towards leg ulcers that had a vascular component to them, i.e. very painful. The overall median pain was 8 across the board, but here you can see different wound types. Next. And what was really interesting is that 100% of the patients, actually 100% of the wounds, reported complete pain relief, all went to 0 except for 1, while the wounds were still open. So if we wanted to look at how fast this happened, by the first visit, which is a median of 4 days, average just over 3, over half the patients had at least a 75% reduction in pain. So fairly significant reduction fairly quickly. And one of the things we did not record, this was actually just in the nurse's notes, is that multiple patients reported pain relief the first day. Next. So if we look at wound closure in that study, 83% experienced significant or complete closure. These were much larger wounds than the previous study discussed, up to 117 centimeters squared was the largest. That person had a base pain of 10 and went to 0 by the first follow-up visit. Also, if we look at the wounds that didn't close, what was interesting is that we still saw significant pain relief, actually even more dramatic than the overall group. 75% were pain-free by the first follow-up visit, which is compared to 39% for the overall group. And in the study, even though we didn't track narcotic usage or drug usage, multiple patients reported stopping narcotic painkillers with CDO. Next. So now I'm going to switch gears and go into studies that are either recently published within the last few weeks, International Wound Journal, for example, with UT Southwestern and Laborie. Also, then Baylor College of Medicine, we have a couple of pilots ongoing there, and those are interim results. Next. So the first I'm talking about, this is just recently published. The full paper can be found on our website. It's open publish. This looked at just a 3-week time period and trying to look at underlying factors why wounds are healing. So we looked at growth factors, cytokines, and wound perfusion. And that's actually non-invasive methods. So it looked at peripheral wound perfusion using TCOM. You can see there in the 3-week time period, over half the patients had at least a 50% wound area reduction. These were chronic wounds going in. And what's really interesting is that the first week we saw significant increases in cytokines and growth factors. For growth factors, for example, ranging from almost 300% to over 800% in things like VEGF, TGF-beta, PDGF, and IGF-1. And cytokines also had significant increases. However, they were a little more delayed. Some peaked in the first week, some in the second week. I'll show you in the next page graph. And as I mentioned before, we did see significant increases in TCOMs, which I was not expecting because that is peripheral to the wound, not in the wound bed. Next. So here you can see the timeline of the cytokines and growth factors. The growth factors are the 4 on the left, the cytokines are the 3 on the right. The growth factors peaked in week 1. Cytokines actually, 2 of the 3 peaked in week 2 and then decreased, which follows a fairly standard inflammatory response to a chronic wound reawakening. Next. And finally, these 2 studies, I'm just going to give you a brief overview. Again, these are also available on our website or at Baylor if you want to look at them up as posters. Our first study is the top left toe amputation study. We were trying to look at preventing tissue necrosis in toe amputations. Because we've seen this in the field, we want to try to investigate this in a more formal study. So this again is a short study. These are amputations, sort of surgical, only a 4-week study. And at 4 weeks we saw, or at interim, we saw no necrosis with CDO, so none of the wounds reopened, versus a 43% incidence of tissue necrosis going on in the control group. If you look at the amount of successful complete healing at 4 weeks, 75% with CDO versus 29 in the control, and a wound length reduction also 70% greater with CDO than in the control group. And because of that wound length reduction, a second study was started looking at anterior neck surgery scar reduction, and this is for thyroid or parathyroid surgery. And what they looked at there was not only better scar visualization, which is more qualitative, but also quantitatively using lasers looked at scar length reduction, saw a 40% greater scar length reduction in that surgery with CDO. And if you look at scars that were greater than 10%, most of the wounds with CDO, almost 80%, were greater than 10% scar reduction versus over 70% in the control group were less than 10% scar reduction. And that is it from mine. So let's turn it over to Dr. Chan.
Thank you, Mark. That was fascinating. And I'd like to introduce Dr. Brian Chan. Brian is an affiliate scientist with the Neuroengineering and Therapeutics team at KITE, part of the Toronto Rehabilitation Institute. As well, he's an assistant professor at the Institute of Health Policy, Management and Evaluation at the University of Toronto. His research focuses on economic evaluations and health technology assessments for individuals requiring rehabilitation, including spinal cord injury. He's published studies on the cost of pressure ulcer management for individuals with spinal cord injury, the cost of hospitalized acquired pressure ulcers, and the cost effectiveness of electrical stimulation therapy for spinal cord injured individuals with pressure ulcers. Please welcome Dr. Brian Chan.
Thank you, Karen, for that introduction, and thank you, Mark, for that presentation of the clinical outcomes associated with CDO, and that is a great segue on what I will be presenting next. If we go to the next slide. Because Mark had presented on, specifically in the first part of his presentation, on some of the positive outcomes that are associated with this therapy, namely the improvements in the healing rate of individuals experiencing diabetic foot ulcers. If we take a look at that from an economic perspective, improvement in the number of individuals healed of the diabetic foot ulcers has to have some sort of economic implications to healthcare system, because you no longer have to treat individuals with diabetic foot ulcers, and they no longer have to go through different types of treatments to try and get at healing. And also they reduce the risk of the secondary complications that occur that are associated with the diabetic foot ulcers. And if you go to the next slide. However, if we are to administer this treatment, there's also a cost associated with it. With this device there that it needs to be used, there is a cost associated with that, with the offloading, as well as the changes in bandages and whatnot. So if we go to the next slide, the question becomes, if we are to pay for this technology so that individuals have access to it, how do we value that compared to the improvements in outcomes that could occur? So there's a cost associated with delivering the intervention, but there may be some cost benefit in the future because of improvements in outcomes. If you go to the next slide. So that is the question that I had looking forward as we conduct an economic evaluation, looking at CDO. And the study question that I posed for this study was to evaluate whether CDO was cost effective when treating individuals with advanced diabetic foot ulcers compared to negative pressure wound therapy from the perspective of the public healthcare payer in Ontario. And so there are some things that we have to focus on here in this study question, that being that this is a cost effectiveness study. So we are comparing both the cost as well as the outcomes of both CDO as well as negative pressure wound therapy. The reason why negative pressure wound therapy was chosen as the comparator is because in terms of accessibility, in terms of the possible ability to deliver this intervention from home, and also a similar patient population for treating diabetic foot ulcers, those reasons were why negative pressure wound therapy was chosen as the comparator. However, when we get into some of the sensitivity analysis, we are going to take a look at some other alternatives as well to see how that affects the results. Another thing to focus on as well is the perspective. So this is from the perspective of the Ontario public health care payers. So the results I'll be presenting to you are for that jurisdiction. So let's go to the next slide. So let's get into some specifics about what was conducted. So we took an individual, and what we did was we projected over a 5-year time frame. We looked at this individual if they were to receive CDO, as well as the associated clinical outcomes that are connected with this intervention, that being the possibility that this individual will be healed at 6 weeks. And then we took a look at if we were to project their over a 5-year period, what their cumulative costs are, as well as their cumulative outcomes are. If we go to the next slide, then we can take a look at what their this individual's 5-year cost and outcomes are. The outcomes of interest in this economic evaluation was the quality adjusted life years, which is, in terms of economic evaluations, is the gold standard, because this is an outcome that can be applied to different interventions, analysis of different populations, because it is a accumulation of improvements in life expectancy as a result of receiving the intervention, as well as the quality of that life. So that's why it's called quality adjusted life years. So if we calculate the cumulative cost and quality adjusted life years over 5 years for an individual receiving CDO, and then next slide. If we then take the same individual and then take a look at if they were to receive negative pressure wound therapy instead, and the outcomes in terms of healing associated with that, and then also project in terms of 5 years, next slide, their cumulative cost and quality adjusted life years, then we can do a comparison. However, we don't want to only focus on calculating this for one individual, if we go to the next slide, but instead we would repeat this 10,000 times for a cohort of 10,000 individuals. And these individuals will change based on their sex as well as their age. And this will be based on a similar population as that seen in the clinical trial that Mark had presented earlier on in his presentation. So let's go to the next slide. Now, to get a bit more specific, what we did to be able to project individuals and their costs and their outcomes over a 5-year time frame was we put them into something called a Markov model. So based on their outcomes of whether they were healed or not, they would be in different health states, mutually exclusive health states. And then over time, individuals have a chance or a probability of moving into different types of health states. And each one of them have their associated costs and associated outcomes. And then we tally that over time. Let's go to the next slide. So let's go then now to the results. I want to start off by presenting to you what we saw in terms of the treatment costs. And in this case, this would be the treatment cost per week. And as you can see, when we had costed out the CDO treatment compared to the negative pressure wound therapy, just the treatment cost itself was much higher for the negative pressure wound therapy. And there are two main reasons for that. First one being the cost of the equipment itself, both the rental and the other costs associated with it, but also the staffing time required for dressing changes, so that being higher for negative pressure wound therapy than CDO. So it comes to no surprise, combining the lower cost of treatment as well as the higher improvements in terms of wound healing, that over a 5-year time frame, when we take a look at a cohort of individuals, that CDO on average costs less and also has better outcomes in terms of quality adjusted life years than that of negative pressure wound therapy. Next slide. What we also did was we took this 10,000 population and we ran this cohort repeatedly, taking into consideration the uncertainty resulting from the outcomes of the clinical trials and some of the model inputs that we've included in our analysis. And we found that when we took a look at all the number of times that we've repeated this simulation over and over, we found that almost 80% of the time we had the same outcome, that being lower cost and higher quality adjusted life years for CDO compared to negative pressure wound therapy. Next slide. We then took a look at some sensitivity analysis, so changing some of the inputs, taking a look at other assumptions that we could make, and taking a look at what the impact would be on the outcome of our results. So we took a look at comparing CDO to hyperbaric oxygen therapy, taking a look at it versus just advanced moist wound therapy, and even taking a look at if individuals were always had debridement at follow-up visits, larger ulcer sizes, greater chronicity of the diabetic foot ulcers. We found that overall the results were consistent, that being that there was a reduction in cost and there was an improvement in quality adjusted life years, showing that depending on the population, if we were to make modifications to the population or the type of treatment that was the comparator, that the results remain robust. Next slide. However, there are some limitations to keep in mind, this being a study that requires projection. There will be some assumptions that occur, this being a study about economics and from the perspective of a specific healthcare system, then there are limitations, of course, that being the results are specific to the Ontario healthcare system and may differ if we take a look at another healthcare system. Also, something to keep in mind was that there is currently no evidence comparing CDO to some of the other treatments that I presented, that being negative pressure wound therapy or hyperbaric oxygen therapy. So we had to make some indirect comparisons in that case. But if there was in the future a direct comparison, then we can provide some updates to economic valuations, and there may be changes to the outcomes, there may not be. But also, there was a lot of assumptions that were required in terms of long-term outcomes because there isn't any studies with CDO that have long-term outcomes beyond 1 year. We had to create some projections, but if there are future studies looking at the long-term outcomes of CDO, then we can have a more robust economic evaluation. Okay, next slide, please. However, based on the evidence that we do have currently, and based on the calculation of the economic evaluations of CDO, we find that CDO results in lower cost as well as slight improvements in quality adjusted life years when we compare it to negative pressure wound therapy. We also see that with hyperbaric oxygen therapy as well as advanced wound dressings. And we find that overall these results appear robust even when we incorporate different assumptions and also include uncertainty into our analysis as well. And the study has been published very recently in the International Wound Journal. And if you'd like more information or read more about the study, you can find it there. Thank you.
Thanks. Thank you so much, Brian. Now, I'm going to take over again, and I've got two interesting cases. Now, these were two cases from PEI, and Kathy Much was involved with both patients. She's unavailable, so I'm going to be presenting them for her. And so the first case is a 69-year-old male who has a history of venous disease. He was wearing compression hose to treat the venous disease. He had no history of DVTs, but did have superficial varicosities and stasis dermatitis bilaterally. Excuse me, he had a history of liver cirrhosis, and in March of 2019, he had a painful lesion in his left medial leg for greater than 2 months. The patient told Kathy that this started as a black dot. When they did their assessment, his ankle brachial pressure indexes were 1.27 bilaterally, and you can see that the wound was 2 by 1.5 centimeters. It had some necrotic tissue, eschar, and some viable wound bed in that wound. He had bilateral leg edema, and he was on antibiotics. So they started treating him with a silver gel. They put him back into his compression hose, and they debrided his wound. And so there you can see a picture of this gentleman's leg, and that was March 11, 2019. March 25th, he missed an appointment. March 28th, he arrived. He was in a lot of pain. The wound was quite a bit bigger, so now we're 6.5 by 5.5 centimeters. And they started him on Hydrofera Blue and Coban 2 Light for compression. April 7th, again, the wound was bigger. There was a lot of slough in the wound bed, both adherent and as well as loose eschar. They continued with the Hydrofera Blue and Coban 2 Light as well. The wound was debrided that day. April 9th, he arrived in clinic with increased pain, reporting his pain was a 10 out of 10. The wound was 7 by 6. The eschar was starting to lift, and there was some granulation noticed, but this individual, because of his pain, wasn't sleeping. He did feel better when his leg was dependent, which obviously increases his edema, and EO2 therapy was initiated with compression. So now you can see what this ulcer looked like on April 9th. But now look at this wound on June the 4th, 2009. So we go from a patient reporting his pain was 10 out of 10 to reporting his pain was now a 0 out of 10. They were able to use EO2 up to this point with a combination of appropriate compression, but because the wound was healing gangbusters, the EO2 was discontinued at this point. It went on to heal and close completely on July 11th, and so you can see there's quite a difference from the before, but also we were able to manage this individual's pain. But then he arrived back in clinic saying he now had a new ulcer in his right lower leg, noting that the ulcer previously I discussed was on his left leg. And again, he reported that the pain was 10 out of 10 with this new wound. And so EO2 was actually started then on the right leg, but by July 11th, the wound was fully granulated, and again, he had no pain. It went from a 10 out of 10 to a 0 out of 10. And this wound closed completely as well. So we have an individual who had significant pain. We were able to manage the pain as well as heal his wounds. The second case is a young person with diabetes type 1, end-stage kidney disease, hypertension, significant arterial disease. He had a BKA, and you can see the amputation site. He had wounds on both sides of the amputation site. And this photo was taken in July, and the team on PEI was trying to prevent another amputation, because this person could have ended up with an above-knee amputation. And as we all know, dealing with amputees, we want to be able to fit individuals for the right devices, and if we can heal a wound with a BAK and prevent another amputation, that's a good outcome. So I'm going to be walking you through the wound healing, because this amputation site has wounds both lateral and medial. So initially, you're going to see the before and after as we walk through the wound healing part. So you can see with the lateral amputation site, we start on July 4th. We still have quite a bit of necrotic tissue on July the 10th and July the 19th. But look at this patient now, August 30th, using CDO. We have lifted all of the necrotic tissue. We've got a fairly healthy wound bed, and the wound size is contracting very, very nicely. September 27th, again, the wound is significantly smaller. We have a little bit of slough in the wound bed, but the CDO was continued. And there we are, December 17th. That actual wound went on to close completely. I just don't have a photo of that closed wound, but I'd like to walk you through now the medial wound from that amputation site. So you can see in 1 week, we have a little bit cleaner wound bed from July 4th to the 10th. And then look at this wound on July 19th. It's got a lot of healthy granulation tissue. There's a little tiny bit of slough, but the wound is responding very well to EO2. July 25th, again, we've got a little bit of necrotic tissue in that wound, but 90% of the wound bed is very healthy, beefy granulation tissue. August 1st, you can see that this wound size has contracted significantly and is quite a bit smaller. And then we have a closed wound on September 27th. So I've presented two cases, one showing how we can manage pain and heal wounds, and a second show how we can heal fairly significant wounds that have arterial disease and prevent a further amputation. Now we're actually going to be turning it over to questions. You're going to be typing your questions into the Q&A box, but I've also put up here emails for both myself, Edie, Mark, as well as the EO2 website. There's quite a bit of information on the website. There are YouTube videos. There's all sorts of white papers, summaries of research that Mark spoke about, but you can also email us with questions that you have. First question, I think I'm going to turn this over to Mark. Hello, I hear you talking about EO2 and CDO. Can you explain to us the difference, please?
Sure. So EO2 is our company name. It stands for Electrochemical Oxygen Concepts, or EO2 Concepts. CDO is continuous diffusion of oxygen. And the reason we use that term is because most people think of topical oxygen as the chambers or bags that have been around. They're intermittent. They're only 90 minutes a day, typically 3 to 5 days a week. We're on 24/7, like a mini respirator.
Thank you, Mark. Actually, the next question I'm going to actually ask you to answer as well, and I may add in a little bit at the end. So the question is, what do you think of the practice of a physical therapist using oxygen with a bag and a tube to deliver oxygen to the wound via bag, either I guess from an oxygen at bedside, or thoughts on that, Mark?
Sorry, the question broke up a little bit. Could you repeat it?
So what do you think of the practice of a physical therapist using continuous diffusion of oxygen with a bag and an oxygen tube inserted into the bag to deliver oxygen to the wound that way?
Oh, so simultaneously?
Yeah.
Okay. It probably wouldn't hurt. The main thing you want to watch out for is not to dry the wound out, because with CDO therapy, we use a fuel cell to generate humidified oxygen. So it's a low flow stream of humid oxygen. It's about 50 to 60% humidity. And that won't ever dry the wound out. In fact, we actually have to worry more about exudate control with the wound. So using any type of other bag or something like that, if it's not humidified, those typically have high flow oxygen. Oxygen by itself is dry, it could dry the wound out. It would stop the oxygen penetrating or hinder it.
I'd just like to add on to that, Mark, that if you used a bag and, oxygen delivered by a tube, you may only be able to deliver oxygen for an hour, hour and a half a day. The advantage of CDO is that it's delivering oxygen to the wound 24/7 because it's a very small device.
It's wearable, correct.
It's totally wearable, and patients can be, ambulatory, moving around. You heard from Bill, and so it's something that can deliver oxygen 24/7. Now this is a question for you, Edie. Can you explain how CDO is installed on the patient?
Yes.
Put on.
It's a very simple dressing, as you heard from Bill saying that he was able to independently apply his dressing. And it's you take the back off the dressing and you put it over the wound, and that is it. There's interlocking tubing that goes, you lock it in onto the dressing, you run the tube up to the machine. If it's a lower leg ulcer, the tubing can go up through the pant leg, and you're wearing the Oxygenie on your hip in a little fanny pack, if you will. And yes, thanks, Mark.
Mm-hmm.
And it's light, and you just turn it on and you have a continuous flow of oxygen 24/7, very easy to manage, no noise from the device, and it's very comfortable to wear.
Thanks, Edie. I think the next question is for Brian. VAC therapy generally cannot bring wounds to full closure. CDO, as I understand, can. Was that taken into consideration in the economic impact?
Yeah, so for the economic evaluation, I used healing rates based on best available literature. So there were some studies showing rates of full closure healing, not at the same level as CDO, but that was considered in the economic evaluation.
Now,
good question, thank you.
Yeah, good question. Next question, I think, is for Edie. Can you put CDO over a wound that has fibrin in it? Or is it better to have 100% granulation tissue for CDO to work?
That's a great question. Certainly you want to prepare the wound bed to receive the therapy, and ongoing debridement, if that's required, is an excellent start. Depending on if you can tell the difference of fibrin and other components in the wound bed, the answer basically is yes, you can put it over top. It does not work well if you try to put the dressing over top of necrotic or sloughy tissue. So you want to remove the devitalized tissue prior to initiating and putting on the dressing.
Edie, I'd just like to add in, there's been a few times when we've had patients where pain is an issue and we've not been able to debride them as well as what we would have liked. And we have had success with CDO. It does help facilitate autolytic debridement, but I 100% agree with you. This works best when the wound has been successfully debrided. Now, another question for you, Edie. What kind of dressings can you use with the CDO therapy?
You can use a variety of primary dressings, but you don't want to use anything that has petrolatum in it, such as Sofratul or items like that. We have used antimicrobial dressings, silver ionized dressings that deal with trying to minimize the bacterial load in the wound bed. Some have actually used gauze underneath the wound bed. And so if the bottom of the dressing does not touch the bottom of the wound because of depth, you certainly can instill a primary dressing into the wound bed. So hydrofibers, calcium alginates are all fine to use. Blue dressings as well if you're trying to clean up an antimicrobial challenge. So anything but petrolatum is supportive to using as a primary dressing.
And if I could add on, a rule of thumb is if water can go through the dressing, you can use it with our dressing, our system.
So as Mark said, if you had a dressing that had an inclusive top layer, you wouldn't want to put that onto the wound first and then try to have the oxygen diffuse through that. I've actually had a couple of questions here about funding, so I'm going to read both questions and I'll try to answer them. What sources of funding pay for CDO and EO2? And as well, how, sort of going along with that, what is the product availability? Are we able to access this in various parts of the country? And let me tell you what our experience is. So currently the product's available on PEI, Nova Scotia, BC, and Saskatchewan. And in addition, 2 other provinces are looking at trialing on some patients. And regarding cost, a CDO is less expensive than negative pressure wound therapy, and you heard Brian speak about that. And regarding the issue in Ontario, I've actually had questions about whether or not the product's available for Ontario health teams. And I wondered if in the question you were meaning the LHINs, because I'm not sure that the family health teams would be prescribing something like CDO. I would see it rather being prescribed within the LHIN by a wound clinician. And at this point in time in Ontario, there is no LHIN that is using the device. We've actually had patients who have been willing to pay for the treatment themselves, but we haven't had a LHIN pay for it. But hopefully that will change in the future as we get more experience and clinicians get more experience and start advocating for this important therapy for their patients. I don't know if anyone would want to add anything in on that. Edie, if you would add anything else, or?
I think that as clinicians do work with the product and see the results and see the cost efficiencies and the wound outcomes from the use of CDO, that there's always opportunity to do the evaluations and support materials management in looking closely at yet another adjunctive therapy and looking at supporting the cost of the therapy. And when they start seeing cost efficiencies, you know, people that are paying for the therapies, government programs, things like this, it does, if you can show cost efficiencies and positive outcomes, there is less of a reluctance to look at another adjunctive therapy.
Great. I have another question about whether or not we ever use an enzymatic debriding agent before using CDO. And actually, we wouldn't want to use something like Santa, which is the only enzymatic debriding agent available in Canada, because it has petrolatum in it. It could be potentially used before CDO is started, as long as you have a bit of a washout period, because the petrolatum interferes with the absorption of the oxygen. And lots and lots of questions about debridement, and which I think we've already answered. Obviously, it's most important, if we can, to debride these wounds, but sometimes it's actually not possible. Another question, what are your thoughts regarding applying CDO in arterial ulcers after debridement? I learned that it's not advisable to debride wounds where blood supply, hence O2 availability, is compromised. Edie and Mark, can you comment on that?
Well, I could comment on it from, for example, the study we talked about with the painful ulcers. Those were primarily leg ulcers that had an arterial component. And so it actually worked better in those for the pain relief. And it worked fine. I mean, you saw overall we had an 83% response rate. And the nurses think that's primarily due to some patients not being compliant, because once their pain went away, they took the device off because they thought they were, at least it wasn't bothering them anymore. But yeah, so we've seen not only in that trial, but also in the field, it seems to work very well in that arena. Edie?
I would just like to add that it's very important to identify what the arterial component of the lower limb is. So lower leg assessment is hugely important, and that the outcomes of those assessments are driving your treatment options. So as a clinician, when you get your ankle brachial indexes back and toe pressures back, you are going to make a clinical decision whether the wound is healable, and if it is, you want to proceed to support that patient and their wound to closure. If the wound is not deemed to be healable, then perhaps you don't want to debride the eschar from that arterial ulcer, and maybe an oxygen therapy, adjunctive therapy, would not be appropriate for that patient.
Thanks, Edie. Another question for Mark. Is oxygen the only therapeutic agent in CDO? Is this technology antibacterial as well? And if yes, then what makes it antibacterial?
Okay, so yes, the only therapeutic in this is oxygen. It's really more of a nutrient that supplies the body to support various metabolic processes. When it's generated by the device, it is basically pure, greater than 99% oxygen. What it does to support the antibacterial process, you can go on our website, and there's also some really good papers by Chan and some other doctors out there that talk about how oxygen works in wound healing, and that's our guidance document. We basically summarize what they've said. But what it does for antibacterial in the wound bed is it supports autolytic debridement and antibacterial activities by supplying oxygen so that the macrophages and leukocytes can use that oxygen to create reactive oxygen species and degrade or break apart not only the dead cells, but also invading organisms such as bacteria and other things.
Great. And a clinical question from someone: how often is the dressing changed? And I'll get started, and then I'll have Edie add in. In theory, what happens with this dressing is like any other dressing, and so it can stay on in theory for up to a week, but as you all know, what happens in reality and what happens in theory can be different. And so initially we see an increase in exudate with using CDO, and so often then initially when we start patients with this treatment, they may have to have dressing changes 3 times a week, 4 times a week, but that actually settles down after a week or 2, and we can go to less frequent dressing changes. But honestly, the frequency of the dressing changes is impacted by the amount of exudate, as well as the type of dressings that you're putting on the wound. And so you're going to want to apply a dressing that's going to be more absorptive if you have more exudate, and so on. Edie, would you add anything to that?
I would. If you are seeing the increase of exudate and you're not using a primary dressing, just the CDO dressing, even with the primary dressing, you may want to use a skin prep to the peri-wound area just to protect it, and make a clinical judgment about the frequency of your dressing changes by checking the dressing after the first 24 hours of application, and making a clinical judgment that maybe you want to change the dressing 2 or 3 times a week, and then extend your dressing change times based on once the exudate levels have leveled off. But certainly using a skin prep in the peri-wound area will protect your margins and reduce the challenge of maceration, and it's a good consideration, especially in the first 1 to 3 weeks of initiating the therapy.
Thank you all, and I'm going to actually close it off because our hour is up. I can't believe how quickly it went by. I'd like to thank our amazing presenters for their engaging talk, and thank you for attending today's webinar, Continuous Diffusion of Oxygen in Wound Healing, Promoting Patient Independence and Cost Effectiveness. If you have any questions, please contact any one of us by email, or contact Wounds Canada at info@woundscanada.ca. You will receive a follow-up email within 48 hours with a link to view the recording of today's webinar from Wounds Canada, along with a survey link where you'll have an opportunity to sign up for more information from EO2. Please complete the survey to provide us with your valuable feedback. And on behalf of Edie, Brian, Mark, EO2, and Wounds Canada, thank you for joining us today, and have a great evening.